Okay, probably the last session of today. Now we will have a multidisciplinary panel with case discussions, and all the panelists are here for cases. We will have 4 cases to discuss, I think. Now I've got a message for everyone watching us that they will join with their questions to us from Zoom and YouTube. So I'll leave the microphone to Dr. Gürkan, and you may begin.
Thank you, Mr. Chairman. So let's proceed with the first case. This is 62 years old male with abdominal pain and GGT elevation, MRI performed, PET-CT performed in another center, and then referred to us. There was no pathological FDG uptake in the PET-CT. I'm leaving the radiologic images to Professor Gürses.
On the axial T2 weighted image, you can see dilatation in the intrahepatic bile ducts. And on the coronal T2 weighted image, there's marked dilatation in the common bile duct. Cystic duct unites the common hepatic duct lower than normal. And there is also moderate dilatation in the pancreatic duct. I don't see any lesion on these images. This is an MRC with a lot of artifacts actually, but there is, again, you can see the dilatation of the biliary system and the pancreatic duct. On the T2 weighted axial images, you can see a small common channel, and there is a nodular lesion, polypoid lesion, which is of intermediate signal intensity, looking like a soft tissue lesion, protruding into the common channel, but it's a very short common channel. And at the ampulla, there is a polypoid lesion in continuity with the one I've shown you. So there is a polypoid lesion at the ampulla protruding into the short common duct. Is it soft tissue or not? How to understand? On the post-contrast CT image, you can see extensive, excuse me, MR image. I'm tired. There is extensive contrast enhancement in that polypoid lesion. So there is a polypoid lesion with contrast enhancement at the ampulla causing dilatation. Shall I comment about differential diagnosis?
Yes, please.
As to summarize, there is a low union of the cystic duct, dilatation of the biliary system, and a nodular soft tissue lesion at the ampulla. This is of soft tissue density, so this is not a cholelithiasis, or this is not a lipoma. This is a soft tissue. But doesn't have any fat inside, so this could be an adenoma. I would suggest as differential diagnostic consideration, this could be a carcinoma of the ampullary region. This could be a neuroendocrine tumor because it is hypervascular in the early phase, and this could be an IAPN, of course, a perineoplastic lesion.
Now, Professor Alper, would you please... I've started the ultrasound.
I showed you this patient morning session. You can see here that the pancreatic duct, dilated pancreatic duct and common bile duct, caulopus. And you can see here that the other pancreas parenchyma is normal, a little fibrotic. There's no signs of the pancreatic mass in this area. The pancreatic duct diameter is more than 5 millimeters. It's about. The other part of the pancreas channel is normal. In the ampullary area, you can see here that the ampullary and common bile duct main channel, maybe. The lesion is in there. There isn't any sign of the vascularity, but we don't use any enhancement contrast material because Turkey has not available for the contrast enhancement. Ampullary. We performed the FMB biopsy in this lesion. Endoscopy.
Can I ask a question?
Yes.
What What is your diagnosis as an experienced expert endoscopic ultrasound? What would you say for this?
I think that I tell IPMN, probably.
So a papillary process occurred in
Yes.
IPMN
Yes.
in pancreatic head.
Yes,
Okay.
in pancreatic duct. Endoscopy view. You can see here that the endoscopy view, the ampullary mucosa is normal. Probably the lesion is inside of the ampulla. Therefore, we don't see any lesion on this area. Maybe we can take a biopsy from this area, cut and open and take a biopsy, maybe. But in this lesion, no enough for the diagnosis of the lesion because the lesion is pancreatic duct area.
So you don't recommend biopsying directly from this mucosal side?
Because
You don't get
this
anything.
side is common by the choledochal side. Pancreatic ducts lower on the
Okay.
side.
Okay. So do you have any other comments?
Ampullary adenoma.
Okay.
With
Okay.
this photo.
So let's proceed with the, we have shown in the morning session, Professor Alper performed an FNB biopsy, and on-site pathologic assessment was done. Now I would like to let the stage to Pınar Fırat for commenting on.
Okay, thank you very much. It's definitely a very cellular specimen. I try to use the cursor. How can I use the cursor? Okay, here it is. Okay, it's definitely a very cellular specimen. And when we get closer, it is definitely papillary. It's not easy to recognize papillary structures on cytology. Generally, the epithelium covers itself and the fibrovascular cores are not there, and it's not easy to define papillae, but we are lucky in this case. Those are fibrovascular cores, and they are covered by epithelial linings. So it is as it is in the histopathology, just a nice reflection of histopathology. So this is definitely a papillary lesion. It's too much crowded, and when we look at the epithelial linings, there is a lot of overlapping among those clusters. And if we look at the individual cells, they have elongated, kind of dark nuclei, some nuclear size variation. If we ask about atypia or dysplasia, low grade, high grade, it's definitely high grade. It is a high grade, it's a papillary lesion showing high grade dysplasia. And that's the nice cell block or FNB. So I can give the microphone to Adsay here because it's exactly like.
Yes, this is a beautiful papillary neoplasm, an adenomatous neoplasm that has high-grade dysplasia. Like I said, in the West by WHO, we're not supposed to use the word carcinoma in situ, but I do not care. We're partly in the East. If you need, I can go to Anatolian site and make my diagnosis there. So I'll be also partly Asian. Joking aside, we call these things carcinoma. I call these high-grade dysplasia / carcinoma in situ. And for practical purposes, a case like this, I call this carcinomatous transformation of a papillary neoplasm. This is a beautiful example of an entity. This is the resection specimen we're looking at right now. Perfectly matching to what Professor Alper showed. Now, there are two comments I'd like to make, please. This is a beautiful example of IPMN of ampulla, like he said, what we now call IAPN, so intra-ampullary papillary tubular neoplasms. They're a little bit different by their rate of cancer formation, by their cytologic profile, some of the molecular aspects, but they're essentially an adenomatous lesion growing within the ampulla inside. So for the term ampullary adenoma, what we want is the adenomatous lesion, just like in colon, to be on the surface of the ampulla, on the duodenal surface. When it is entirely growing within the ampullary channel, we call it intra-ampullary papillary tubular neoplasm. Just finished the chapter for WHO for this, and this is how it's going to be called, unless they change the editors change it in the last minute, which they do. So this is intraampullary papillary tubular neoplasm cut section. Now what we did is to show that section is kind of almost amputated the ampulla. So you're looking at the tangential cross section of the ampulla. The pink band here is the OD muscles. You see the duodenal surface is perfectly fine, just like you saw in endoscopy. The mucosa is stretched, but otherwise was unremarkable. What Dr. Gürses showed as soft tissue, indeed, they are soft because they're papillary elements, and you see it in the gross section here. And again, carcinomatous transformation. In a case like this, we need to do a complete examination to make sure there is no invasive carcinoma. And this was one of the rare non-invasive examples. So let me go back to this photograph and again say something to the gastroenterologists in the audience. You saw this. I think ampulectomy could be very tempting because it's nicely protruding towards you. Even I feel like I want to go inside and carve it out. The problem is many times invasive cancer is deep in the upper part, inner part. I'll show you. We didn't find invasion in this case, but we often do. So I don't think these should be subjected to ampulectomy. Ampulectomy literature is yet another one where they follow the patient for 2 years and they say how perfect we are. In 2 years, nothing happened. These are slow growing tumors. We have a lot of these cases. Some of them come back many years later. We have 2 non-invasive examples of IAPN that recurred 8 years later. I don't think ampulectomy is appropriate for them. Here's a deeper section. So this is for the pathologist in the audience. Now we do, instead of bivalving, because in bivalving we have to probe the ducts and it kind of pushes the papillary or polypoid lesions outside. So we don't like that. So we are doing this duct-centric cutting, and you see here a common bile duct. And this is the pancreatic duct. In this case, as it was illustrated earlier, the polypoid lesion extended to the pancreatic side a little bit more than it extended to the common bile duct side. More fascinating here, Dr. Alper tells me that diverticulae are common in this region, but we have a beautiful diverticulum. This is intestinal invagination in this area. I often wonder if these anatomic variations have a role in obstruction, chemical milieu change, and maybe participating in tumorigenesis, but that needs to be proven. In this case, there was no invasion. For pathologists, these can be problematic because the dysplastic adenomatous lesion often extends to branch ducts pagetoidally and shows these kind of invaginations that become very difficult to tell whether it's true invasive carcinoma or not. In this case, we think it is non-invasive, but it can be difficult at times. Here's another example of IAPN, by the way. They all look very much similar to this. The mucosal covered lesion, often the ampullary orifice is dilated, patulous. In this case, there's double orifice, interestingly, and you see the intra-OD adenomatous lesion, very striking, IPMN-like lesion of the ampulla. They are essentially counterparts of ITPN, IOPN, ICPN, all these things that we mentioned earlier, a lot of abbreviations. Bottom line, there are adenoma carcinoma sequence, but it's important to name it properly because the rate of cancer formation is different. Here's another IAPN. Look at the common bile duct and pancreatic duct. The tumor can show a little bit different growth patterns. In our experience, 80 to 90% of IAPNs prove to have invasive carcinoma. And again, that invasion is small and can be upper in the duct. That's why ampulectomy would be very tricky to perform. I would, if I was the patient, I would definitely not want that. If people is feasible, I think that would be the way to go. Often invasive carcinomas in arising these things are small, but they have budding, LVI, and all the aggressive features we attribute. And lymph node metastasis rate is not also trivial, although they are small cancers. They can have lymph node metastasis. So we thought this was a very nice, striking example of IAPN. And again, the point being, it is recognizable by endoscopy readily with the stretched normal mucosa and the lesion inside the ampulla. There's no conventional cancer that will do this. As Dr. Gürses had mentioned, neuroendocrine tumors can look like this, but this is a little bit too elongated for that. Especially ampullary somatostenomas can form this kind of nodules in the ampulla, but otherwise this will be, now if I see this, you can readily make the diagnosis that this is IAPN. and send the patient to resection.
Well, that was actually, I was planning to ask what about ampulectomy, but Professor Adsay killed that question. So the problem is, as Professor Alper showed beautifully, that tubulovillous structure you see in the ampullary region partially into the pancreatic duct, then you need a cytologist, as our team told us, go for it. This is minimally, at the minimum, high-grade dysplasia. Because you sit there with the idea, discussing with the patient, you should be getting Whipple. Making a decision for Whipple, performing Whipple procedure, you really need, if in this case, you need some pathologic clues to go for it. And I would like to thank to our team because they made many things easier for us. I can imagine lacking this kind of possibilities and sources, it would be quite difficult to make such decisions. So no need to discuss after this pathological evaluation. What about the alternative surgical strategies? No chance for endoscopic ampulectomy, no chance for surgical ampulectomy, transduodenal. Any questions about this case from Zoom or from the floor?
Ampulectomy, polypectomy.
No. We performed 10 years ago ampulectomy in the same lesions, but the result of the ampulectomy is not good for the survey of the patient.
I want to ask a question. Even the surgical margins are clear, still the progress is the same? Still bad? Even the surgical margins are clear.
Yeah. So the data about ampulectomy, you're asking. So surgical, the problem with that is, again, we're making extrapolations, but so there's no data on that. I checked this literature very carefully. There are ampulectomy, especially French group, so on. They advocate ampulectomy a lot. If you look at their data, their median follow-up is about 2.5 years, which is totally inadequate for these tumors. Like I said, we have multiple cases. Even after Whipple, they had a recurrence upper in the bile ducts. So many times invasion, you can take out adenoma is very spread throughout, but invasive carcinoma can be very patchy and it can be underneath what you dissect. So I will tell you, so you do ampulectomy, I will tell you the margin shows only low-grade dysplasia and you'll be assured that that's not a problem, but invasion will be farther up in the duct. And considering 80 to 90% of these have invasive carcinoma, and when they're invasive, they are nasty, I think ampulectomy will be a very tricky proposal for these tumors.
More than one perspective.
Staging TNM. Yeah, TNM of ampulla is very confusing and difficult. One thing, we have a large study coming up on that. I recommend pathologists to definitely measure the invasive carcinoma size and report that. That is the only independent prognostic factor we have been able to find. TNM staging of ampulla, the last edition, they changed it based on our papers. It's improved, T1, T2, 3, but still the survival correlation of those T stages is totally imperfect. But if you rely on the invasion size, then it predicts the behavior much better. So yes, if there's invasion, we give T, but this is TIS in situ. This.
Professor Alper.
Generally speaking, surgical ampulectomy is insufficient for periampullary tumors. But specifically in this case, the tumor is very small, and the stem of the tumor is, according to radiologic findings, very narrow. So for this case, not generally speaking, surgical exploration and ampulectomy may be sufficient. According to frozen section examination, and especially the histologic appearance of the radix of the lesion, we may think that this operation is sufficient. If there is a wide invasion area at the stem of the lesion, we may return to Whipple operation at the same session. Generally speaking, to prevent the misunderstanding, we don't advise ampulectomy for periampullar tumors, but especially for this tumor, I will prefer surgical ampulectomy.
So this tumor proved to be non-invasive. So I appreciate that, and I think it's a very good advice. This tumor proved to be non-invasive, so it would have been beautiful to do surgical ampulectomy to this one. But again, 80–90% of the time, there'll be invasion, and if that invasion is less than 2–3 millimeters, lymph node metastasis rate is about 10–15%, which is not trivial. But when you have more than 0.5 centimeters invasion, which is difficult to detect, lymph node metastasis rate is 42%. So I think the issue here is that these are not as like colonic adenomas. They have higher rate of lymph node metastasis, and ampulectomy will not take care of the lymph node metastasis. So that will be the, I mean, I think again, French groups are advocating it, but their data is not reliable to assure that they are curative procedures.
Okay, thank you for the first case. So we can continue with the second case.
Okay. 74 years old female, and osteoporosis detected during dental treatment. Complained itching after the initiation of osteoporosis treatment, and then medical treatment stopped and CT performed due to this itching complaint.
This is a video contrast enhanced CT examination. Here you can see the dilated pancreatic duct. Please follow the dilated duct to the proximal portion. And there is now abrupt discontinuation in the duct, and at that part of the pancreas, the unsnake process and the head, there is a lesion, relatively demarcated lesion, which is heterogeneous. Now I will show you the axial and coronal. It's finished. Excuse me. And now you can see on the coronal CT image on two different sections, the mass lesion at the proximal part of the pancreas. It has relatively demarcated contour with lobulated borders. You can see pancreatic ductal dilatation and more pronounced common bile duct and intrahepatic biliary ductal dilatation. There was no arterial invasion. If this is a malignant lesion, we have to stage it. There was just less than 90% close contact with the superior mesenteric vein. There were some lymph nodes at the peripancreatic area, less than 1 centimeter. So this looks like a malignant pancreatic lesion. There was no metastasis in the lung.
Alper from the US, this patient.
This was
There is a,
right?
yes. You can see here that the portal vein, supermesenteric artery, splenic vein, and middle Yes, you can see here depth, vascularity, supramesenteric vein, portal vein, splenic vein, inferior mesenteric vein, and the other side is hepatic artery, the upper side of the hepatic artery. Yes. The upper part of you can see here the common bile duct. Yes. Hepatic artery, common bile duct, and pancreatic duct now. Biraz ilerledik. Now you can see here the lesion in like a tomography. The diameter of the lesion is about 3 centimeters. The margin is not irregular margin, and there is a different part of the lesion in this area. There is, you can see here that the vascularity, capillarity, the capillarity of the lesion is little. The other part of the pancreas.
So before calling out the name
We
of the
have-
pathology, what was the indication of endoscopic ultrasonography and biopsy on this patient? Do we have to do that?
I don't know. I don't remember it. Generally, we have to perform.
Refer it with
With this
the
result?
mass.
Okay, I got it. We have got a solid mass and the double duct sign.
The direct surgery.
So yeah,
Your opinion.
Yeah.
Yes, yes.
I'm asking for the discussion. What is the reason of biopsy now in this patient?
Now,
Use direct surgery
Uh,
in this patient.
Bengi,
It was somewhat demarcated, so it was not very, very typical for an infiltrative hypovascular PDAC. Maybe that was the reason.
But then question is, even that should be resected.
We have
Is
a
that-
Yes, of course.
Even that should be resected,
Yes.
right? That's what you're saying.
We have a 3 different patients. The endoscopic view, tomography and MRI view, it's about pancreatic PDAC, but biopsy results lymphoma.
Okay.
3, yes.
I was going to
Therefore,
mention the same thing.
We perform generally US biopsy from the surgery, before the surgery.
Yeah, I opening the mind for discussion. Okay.
Yes. There's a different area in the middle of the lesion, and I performed the FMB biopsy to the
Center.
different area, center of the lesion. FMB needle. Generally, I use FMB needle for the solid pancreatic duct adenocarcinoma for the diagnosis. The tough lesion, and yes, I prepare the needle for the exact target area, and now, yes, my target is in this area.
now, after the biopsy,
We've got a wonderful specimen again. That's number 1, as I said before, and we need good material, and it's perfect. It's full of cells, as you can see here. Again, maybe a little bit similar to the previous image that we have clusters. However, this time they do not have those fibrovascular cores, but this clustering and kind of monolayering, even though it's not so regular, is a sign of adenoid grouping. So when we, oops, what happened? Sorry. There should have been some other, may I go backwards? Okay, probably we don't have another image, but you can easily see those clustering cells plus some dispersed cells in the background. We can see them at higher magnification, so I'm not commenting on their cellular features, individual cellular features, but let's move to the other one. Oops. Sorry. Yes. Okay, that's the FNB. FNB clearly shows two different morphology. I mean, in between those adenoid malignant cells, I mean, adenocarcinomas, this is so clear, a very complex glandular structures, and the cellular details are definitely in favor of malignancy. This is the adenocarcinoma part, but those are the cells which were singly distributed in the background of the slides. And if we go for, they look a little bit monotonous, but still they look high grade. And when we do some immunostains, those adenoid structures are not staining. However, the kind of monotonous or solid areas are positive with a neuroendocrine marker, and much nicer with CD56, even though endocrine pathologists do not like CD56 much. It's a very nice neuroendocrine marker for high grades. As a lung pathologist, I love it. And again, the adenoid structures are negative, but the other component is clearly positive with neuroendocrine marker. And this is in contrast with pancytokeratin, the glandular malignancy. Adenocarcinoma is densely positive with cytokeratin. However, a very weak staining for the second component. So it seems that this is a combined tumor, and the Ki-67 is definitely high in the neuroendocrine part. So it's a high-grade neuroendocrine tumor, means neuroendocrine carcinoma, high-grade, plus adenocarcinoma, which we more commonly give that diagnosis again in the lung. However, it does exist also in the pancreas.
By the way, that 56%, we really did sit and count carefully, because there's literature from Sorbia, the Swedish group, on neuroendocrine neoplasms. They found that 55% is where we were discussing earlier in the morning. 55% is where cisplatinum starts to work, and under that, you shouldn't give cisplatinum, was their conclusion. So when Çisel counted this, she came as 55%. I said, no. It's either 54 or 56, one or the other. You cannot give me 50, 54, 55. So it was 56, and then actually in the resection it proved to be 80%. So yes, this is a large cell neuroendocrine. It's extremely rare. I don't want anybody to think that we see these things. This is the first example of true adenocarcinoma admixed with neuroendocrine carcinoma of this kind, convincingly like this in the pancreas that I've seen. There are examples like this, but not quite as good. Now, the thing is, of course, Emrah is, hits the bullseye, and it becomes a problem for us sometimes. And this is one of those cases. If he just stayed in the periphery of the tumor, we would have given the adenocarcinoma diagnosis, and it would have been much easier. But when he went to that, exactly that area that he showed, that other nodule, that's actually where all the neuroendocrine cell clusters are. The neuroendocrine carcinoma component is, and that's actually looks like a polypoid lesion in the duct. This is one fascinating thing. A lot of these peculiar tumors, like osteoclastic one that I showed earlier, adenosquamous, and these things, they start as a polypoid lesion in the main duct and then become more aggressive. And you can find that residual intraductal polypoid bizarre lesion for some reason. They're exposed to peculiar chemicals there, and they have this plasticity. Who knows? So our diagnosis was this is a PDAC, and there was a mixed neck component, again, very rare. In resection, Ki-67 was 80%. Now, one thing is, for this is mostly for pathologists, WHO uses MINAN and MANEC, and I'm on those chapters. I think these are all terms for conceptual purposes. A diagnosis should not be MINAN or MANEC. Instead, we give the diagnosis, this pancreatic ductal adenocarcinoma, 3 centimeters, and there's a neuroendocrine carcinoma component that is so and so. Now, one thing about these mixed neuroendocrine carcinomas in the GI tract, there's evidence that they need to be treated like neuroendocrine carcinoma, even if it is a small component, 3, 4, 5 millimeters, because eventually that's the part that explodes and take over and kills the patient rapidly. When they biopsy these metastatic things, that's what we see. But in the pancreas, this is extremely rare, and PDAC is already a bad cancer. So when the question came up whether this should be treated with FOLFIRINOX or a neuroendocrine protocol, we don't have any data. There are no control studies. These are extremely rare, but it makes sense to me that this will be FOLFIRINOX at least at the beginning, and then later on, if it starts to behave like neuroendocrine carcinoma, then perhaps treating it neuroendocrine, because it's a very small component, polypoid, and may not be that significant. Only time will tell. Any questions?
Thank you. Are there any questions for this case?
Mustafa Hocam?
I want to start some debate, especially the resectable pancreatic tumors like these. A preoperative biopsy is needed or not? Our practice, if we have high suspicion about the lymphoma or autoimmune pancreatitis, we prefer the biopsy. Otherwise, we choose the surgery first. No need biopsy. Especially surgeon members of need it or not.
For this case, not biopsy before surgery, not needed, I think.
I can tell you, I don't know, John first.
We wouldn't request biopsy for this type of cases. And I couldn't understand why you did the biopsy.
Yeah. So maybe if I can just say one thing on that. You know, in Europe, and this was discussed just recently in Lisbon. In Europe, this is exactly the approach. They don't do biopsies. Bühler, none of those guys. That's immediately they go to surgery. In the United States, nobody will operate on anybody without a biopsy. So there are totally different cultures, and in most places in the US, they will do FNA, or because that's kind of the standard protocol for them to continue, and their payment protocols is also linked to it. There are groups, of course, are much more surgery prone, but typically they will have to request the biopsy first. That's why actually we were seeing that where I worked, I was seeing FNAs and Baldock brushings even more so than here from every case. Yes, sir.
Yeah, as far as I know, it depends on the neoadjuvant protocol of the institution. If they send all of the pancreatic tumors to the neoadjuvant treatment, they need diagnosis, so they take biopsy. But
even in the US, even if it's not a neoadjuvant resectable, they do the biopsy for medical legal purposes. Yeah. I mean, there was one time actually, despite biopsy, my best friend surgeon there did an operation, proved to be autoimmune pancreatitis. And then he said after that, and he was sued, and he said after that, I'm not going to do any operation from now on unless there are at least 2 biopsies performed. So this is a common practice in the US. I can assure you, they do biopsies virtually on every patient before they get doing a Whipple.
The reason they are doing biopsy in every case,
medical legal.
From legally, they may need not to go to court.
Yeah. Exactly.
The other one, if you send to this type of patients to, let's say, endoscopy department, this is a kind of
extra work for the different groups. Correct.
I don't want to say, but you understood.
Yes. Yeah, that's understood.
Some kind of insurance.
But also the paternal medicine concept too. You know, if it turns out to be a negative tumor as pseudotumoral pancreatitis, it's not as big an issue in Europe, clearly, because I asked these questions to European surgeons. They just tell the patient that's how it is. You know, some cases prove to be like that. That you cannot do in the US. That's not a good answer. But so it happens. So it happens, but you give $1 million in return.
So 10 to 15% of the pancreatic masses are benign. So I think it is acceptable to see some kind of patients.
Yes, of course. And even in the best hands with biopsies, you still have 4 to 10%. Yes, no question.
Yes, but we are not in Europe. We are not in the United States. So most of the people should draw some conclusions from this meeting. So we have a message to, for instance, to Turkey. So it shouldn't mean that every pancreatic mass who comes in with itching, with bile duct dilatation, with pancreatic duct dilatation, and again an operable mass in the head of the pancreas should undergo endoscopic ultrasonography, a biopsy. We, as old school or some new school, we always do surgery in those cases.
Can I give you three different patients, example patients? One of them, the patients of the Gürkan Tellioğlu, 45 years old female. The patient referred to the surgery, pancreatic adenocarcinoma. The biopsy result is lymphoma B cell. And the other part of the patient, for my patient, for the surgery, T cell lymphoma.
I got you, sir. I
Ama
understand.
lenfomanın radyolojisi farklıdır biraz.
Radiology. Yes,
No,
tell the
No,
doctor.
I have chosen this debatable cases on purpose because this patient came to our center for second opinion. Another surgeon suggested direct operation, no need for biopsy. And because of some atypical findings on imaging and 75 years of, 4 years of age, I tried to get more biopsies. I accepted. Probably I quite feel like I'm living in the United States. I just, on the medical legal perspective, I'm trying to, that lymphoma patient came from Yugoslavia and diagnosed with cancer.
Yes, other.
She had the biopsies, everything. But what happened was I was for a meeting outside of Turkey. They let me know that the patient is going to be in Turkey on Monday. I said, I'll be there Friday. The resident, I don't know for what reason, resident asked for blood tests repeatedly. The patient came with 5, total bilirubin level 5. And 1 day later, it went to 4. 1 day later, it went to 2.5. And the day of operation, when I came, I asked, why did you repeat all these tests? And it's going down. What is wrong with it? Check this again. When we repeat the blood test, it came 1.2. And I said to Emrah, just take to the endoscopy suite. And when he checked, he said, this is not typical pancreatic ductal cancer. We made the biopsy, and then it came out that it was B-cell lymphoma. You're right. There are some differences in radiologic imaging, which lets us force the biopsy. But sometimes, as in this case, mixed type of tumor, maybe the neuroendocrine carcinoma component would have let us start neoadjuvant before operation because of this type of histology. I try to use more biopsy. I know this is going to be operated, but just to be on the safe side.
Yeah, I think safer zone for the surgery.
Ama öyle ya da böyle alınan o ince iğne, EUS eşliğindeki ince iğneyle tedaviye gitmemiştir. İlla ki bir lenf nodu yine de çıkarılmıştır o vakada herhalde.
Yok. Çok sayıda lenfoma vakamız var sadece FNA. So we have, we have FNA diagnosed lymphomas that go to treatment based on that.
Yeah.
Common bile ducting.
Repeated biopsy for flow cytometry. I convinced the patient. I asked her to do the second endoscopic ultrasound, and then we treat it without operation.
Yes, but one important thing is, of course, the logistics, as Koray just said. The logistics is also important. So, here we are very spoiled in the sense that, like in the US, where we discuss the patient at 7:30 meeting, and Emrah who just questioned often is the patient hungry? MPO, so I can do the US right now. So when we have that kind of luxury, of course, I mean, US is done very quickly, and the result comes, we do immediate evaluations. So we do not delay the operation more than a day or two. The only thing is, and the complication rate is very low too. Is it adding a lot? I don't know, but is it deleting or harming? Most of the time we don't see any harm in doing it either. So, but I know in other practices, it's not as easy to get a US FNA biopsy. It takes time. the interpretation of FNAs takes much longer. We're a little bit, our logistics is a little bit different in this institution in that regard.
Lymphoma is very exceptional result for this patient. And for your patient, it's very typical suspicion for adenoid cancer. Very typical. But this result supports our theory. If you have a suspicion, no biopsy, direct resection.
We love biopsies. At least we learn.
Ben Volkan hocama bir şey daha soracağım. Biz GIS'te maneklerde %30'un üzerine çıkarsa komponent tanıya taşıyoruz.
Evet.
Burada
çok yanlış. Çok yanlış. Çok yanlış. Yeah,
yani
the question is in Manek,
bu genel
WHO recognizes, yes, I'm part of that chapter and we discussed this at nauseum. In GI, they recognize Manek if the neuroendocrine carcinoma component is 30%, the patient is going to die in 6 months. There is overwhelming evidence in the literature, and we're just doing yet another study with Cleveland Clinic. Even a small neuroendocrine carcinoma component, it behaves like neuroendocrine carcinoma. It does widely metastatic disease. It responds to cisplatinum. Response meaning it goes away, of course, comes back in 3-4 months, but it shows all the behaviors of neuroendocrine carcinoma. They do biopsies on those patients. The biopsy often shows neuroendocrine carcinoma, not then like lung metastasis, bone metastasis. It shows neuroendocrine carcinoma. Although the primary tumor was just 3-4 millimeters neuroendocrine. Big adenocarcinoma, small neuroendocrine. So there's overwhelming evidence that even a small neuroendocrine carcinoma component should be reported. How they treat it is not our business, but there's no question if you see even a small component, you should report it. Management can be discussed separately. No, I know. I mean, when we read the Bible, right, or Quran, whatever you want to call it, it says 30%.
Okay, nice discussion, but let's carry on with the third case.
Okay, this is the third case. 67 years old male, abdominal pain was a complaint. He had an history of pancreatic cancer in his brother, uncle, breast cancer in his aunt, and endometrial cancer in another aunt. So with the computer tomography,
you can see on the left side the arterial face and on the right side venous face images. There is a really demarcated lesion at the proximal body part of the pancreas. It is around 3.5 centimeters. You can see the ductal dilatation distal to the lesion, and there seems to be some parenchymal atrophy. The lesion is adjacent to the celiac bifurcation, but there is no objective sign of invasion. There is peripheral rim-like enhancement, and the central part of the lesion doesn't enhance with contrast. It's hypovascular, maybe necrotic. On the venous portal face image, you can see that the lesion is very close to the SMV and portal confluence. On the coronal image, you can again see it's adjacent, but there was no objective sign of macroscopic invasion. And these are the outside MRI images. On the axial T2 and coronal T2 weighted image, you can see pancreatic ductal dilatation and the demarcated mass lesion, which is not typical for classical PDAC. After contrast administration, again, MRI showed peripheral rim-like progressive enhancement in the lesion. And there was no thoracic metastasis.
What are the most atypical part in this imaging that you especially mentioned?
The demarcated feature of the lesion. It doesn't look like classical infiltrative PDAC. It looks like some subtypes of PDAC, like metaplastic, I think, adenosquamous. We also call them centrally necrotic type, or like neuroendocrine, but it doesn't look like a low grade. This was the main abnormality, and I didn't see involved lymph nodes around the lesion.
And then we performed.
And really, the lesion was necrotic. After several aspirations, still few cells. Here you see, oops, sorry. Here you see those clearly hyperchromatic nuclei and binucleation and differences in their shape and size. So they are very abnormal cells looking malignant, and they've got a cytoplasm. And you can even say that those cytoplasms are eccentric, so looking very much like an adenoid cell, actually, looking very much like a epithelial cell. And you are in the pancreas, and somebody's telling you that has a family history and some malignant mass, and you're dealing with pancreas, just few cells. The question for us in this case might be whether I should call this case malignant or not, or should I stay a little backward and just say suspicious for malignancy, but we call it malignant. And of course, they look very epithelial. So, and looks like adenoid cells. So, okay, consistent with a high-grade adenocarcinoma, maybe. So they look like carcinoma cells and malignant. And that's all I could say. I'll come back again.
So yeah, like Fırat said, the cytology is clearly malignant and it looks very epithelial. So it looks like a bad carcinoma, bad cancer. We see some of the more cytologic preparations here of the cells. And in gross examination, this tumor was very hemorrhagic, indeed demarcated and with central necrosis, as illustrated in these sections. It's the photographs are not that great, but this is viable tumor here. And on the lower left, you're seeing all necrotic material. The center here is all necrosis, and there's some viable tumor in the periphery. So indeed, it's a central necrotic, demarcated malignant mass. So it looks like those metaplastic carcinomas. But when we looked at the cytology of this, with this peculiar serpentine nucleolar formations and abundant vascularity, we thought this could be epithelioid angiosarcoma, and indeed, the spatial stains confirmed with this is ERG, and it's a good endothelial marker. This is CD31. The positivity of these two endothelial markers nailed this as epithelioid angiosarcoma. This is extremely rare, very, very rare. We have a handful of examples of these, and some of them are clearly arising in the background of adenocarcinoma. And that's a very peculiar thing, you know, adenocarcinoma, angiosarcoma, totally independent tumor types in theory, but in thyroid, this is a well-known phenomenon. Anaplastic thyroid cancers can have angiosarcomatous differentiation very prominently. It's actually not uncommon in mountainous regions, in Peri-Italy and also in Turkey. And we see the same phenomenon in angiosarcomas. Most of the ones I've seen, again, handful examples, had some carcinoma in the background. In this case, we couldn't find an adenocarcinoma component. It was all epithelioid angiosarcoma. PET. I don't know if you had PET. I don't remember, to be honest with you.
Okay, we don't have PET CT for this case, but why we wanted to share with you, this is a very extraordinary case that operated and received this angiosarcoma definitive histopathology. This is the second month after operation. It's just like the patient didn't get any operation. All the mass came back immediately. And the survival of this patient was almost 2 months. At the end of the second month, we lost the patient. So this is a bizarre pathology that we see some extraordinary cases, but this was the most severe one. And just wanted to share you, might be a biopsy operatively, but the definitive biopsy can change everything. If we had known it before, of course, we wouldn't prefer to operate this patient. Any question about this?
May I comment on the cytologic diagnosis of angiosarcoma? It's nearly impossible if you come across this tumor in an unusual site, because it clearly looks like carcinoma. It's quite difficult, like a simple twist of fate. I mean, it's the nature of the lesions, always a problematic issue, unless you have a clinical clue, or unless you think about angiosarcoma. It's definitely difficult pre-operatively.
Thank you. Any questions about this case?
Nadir bir görüntü nedeniyle.
So should we perform
What
PET
was
CT to
the
all
change?
patients with, is that the question?
What would it change? Maybe we're going to show the distal metastasis or what?
The issue
Raised
was local
malignant.
recurrence, not systemic recurrence. Well, in this case, yeah, in that case, if there is a distant metastasis, we always check. These patients have thorax computed tomography routinely. So we didn't suspect any distant metastasis. And we have the abdominal imaging.
Epithelial angiosarcomas behave this way. This one behaved very aggressively. They are not all like this. So
Yeah, should have been treated that. Yeah. Any BRCA mutation in the family? I wondered.
Well, I remember we have asked actually the family to go for molecular kinetic investigations, but we didn't get.
It's a black box. It's very problematic. We send patients to genetic analysis. We would like to know what the results are, and we never know what the results are. I know it's patient privacy thing, but it doesn't have the patient. The patient comes back to the tumor board. We still don't know if the patient has BRCA. That could change the treatment. Only the genetic department knows the results of these tests because they are not part of the patient record in the hospitals by regulation, apparently. And it's a problem for management. As HPB, maybe we can advocate. I know. It's just a joke.
This patient preoperative CT showed that the tumor nearby to the celiac axis and SMA.
Yes.
Maybe could think to neoadjuvant chemotherapy. Probably after neoadjuvant chemotherapy, they show that they like this because the surgery maybe no need this case because just 2 months and local recurrences. What do you think about this case, the neoadjuvant chemotherapy?
In this case, the preoperative imaging was not locally advanced. It was borderline, but surgically operable borderline. So we didn't have any biological borderline issues, no idea about this kind of histopathology. We are increasingly using neoadjuvant treatment in pancreas masses. We have now more than 110 patients who have been operated after completing neoadjuvant, but in this case, prefer to go for operation. But you are right. If we have chosen the neoadjuvant treatment in this case, then the patient could have been saved from an unnecessary operation. That's why the main focus for this group of patients, we are trying to understand the biology of the tumor. The selection of the patients to go for neoadjuvant, starting point resectable, but biologically unfavorable, like CA99 level 1000. We send those patients to chemotherapy to be able to understand what's going to happen within 1-2 months. You're right about that.
I'm talking about adenocarcinoma.
During this operation, tumor rupture, because this looks like an intraoperative dissemination a little bit.
Well, actually, nothing special that I know about this operation that we retrospectively accuse the situation due to the technical issues. It's a total pancreatectomy without any event. And after this pathology came based on the specimen, that was the period, like 2 months ended.
The specimen looked intact, but it was, of course, protruding like many masses, soft tissues, but totally intact.
So may I proceed?
So your previous answer was about adenocarcinoma, right? Not for the angiosarcoma.
No, yeah, adenocarcinoma, of course.
Okay, because if we prefer to give neoadjuvant chemotherapy to this patient, the result will be the same. I think the surgery will be was the only shot for this patient. The resectable angiosarcoma. So why did you think?
If you start with a treatment in 2 months, see like a picture like this, you would say that.
Sure, but before surgery, we know that this patient is angiosarcoma, right?
Adenocarcinoma, right? Not the
In
adenocarcinoma.
Sorry, the preoperative biopsy was adenocarcinoma. Now I get it. Okay, now I get it. Okay, now I get it. Okay.
okay.
We wanted to show cases here that, life is not always perfect, so
Yeah.
sometimes we don't exactly know what we were dealing with. Yeah.
Okay, may I proceed?
Please.
This is the last case. It is not proceeding. Okay, this is the last case. 44 years old man, abdominal pain, pancreatic mass, EUS biopsy, invasive carcinoma reported in a center. The patient went to another center, and in that center, imaging based on that biopsy, invasive cancer, liver metastasis, FOLFIRINOX treatment started. After 2 cycles of FOLFIRINOX, the patient came to our outpatient clinic for second opinion, just to ask. And it's twisted, but this will be the biopsy. Let's not lose time, and
This is
you
the
can comment on
outside
there.
FNA actually, but unfortunately we do not have cytologic slides. Maybe the previous pathology department also didn't have a cytologic slide, just have the cell block, because that occurs. I see this in our consultation cases. Sometimes smears are not done, or they are very poorly cellular, just cell blocks are existing. So this is a cell block section. It's not an FMB. So the cells are just within the blood. If you look, they look a little bit monotonous, but I stop here. I don't continue. It's going to be a spoiler.
Okay, now I just want to.
Well, this is called an adenocarcinoma. Yeah, because it's, well, why it is interpreted as an adenocarcinoma, I think, because they look a little bit pleomorphic and the mind is so much looking for adenocarcinoma and they don't see the real architecture because they don't have the cytologic smears.
Yeah.
If we had the smears, probably they wouldn't do this mistake. So this is so monotonous. Yes, I agree.
Everything started with the imaging. When I saw the imagings, it simply told me what I've learned from my expert radiologists. It didn't look like a PDAC liver metastasis. It was completely different. That's why I requested the samples of biopsy to make a consultation with our pathology department. And I asked to my radiology department what would be their comment. These are the cytologic, so I'm, okay. So anyways, the previous sample was evaluated as neuroendocrine tumor. And because of this technical issues, we didn't want to have any trouble. So we also performed liver through-cut biopsy, which came out also neuroendocrine tumor.
I think this was before neuroendocrine diagnosis was concluded by our pathology department. Here on the CT image, the first thing you see is a lobulated nodular structure, soft tissue, hypervascular nodular structure in the mesenteric bed. You can also see it on the coronal image. It looks discrete from any other organ. There was another mass, similar in density, both had millimetric calcifications inside, but this mass was different. It was adjacent to the pancreatic uncinate process. It was like giving the impression of a pancreatic tumor, hypervascular tumor with an exophytic growth. But with careful analysis, I will show now the hypervascular liver metastasis. So this was different from adenocarcinoma. We had hypervascular metastasis in the liver. So we had to now try to find a hypervascular primary. And with careful examination, we found a hypervascular lesion in the duodenum, as you can see. It's a submucosal intramural hypervascular lesion seen on axial and coronal images. This was the primary, and this is very typical for small bowel neuroendocrine tumors. The tumor deposit and the hepatic metastases are mostly more prominent. You first see those lesions because they are bigger, but we have to know this entity as radiologists and try to find the primary lesion in the small bowel. And we need arterial phase imaging for this because they enhance contrast maximally at the arterial phase. Do you have any questions?
You have. Now, the reason why we wanted to discuss this case was this is such a teamwork. Now, another center making a biopsy, giving a report, the patient going to another center, oncologist, without checking the imagings by herself, just reading the report, because it is reported a pancreatic mass, liver mass. So biopsy shows invasive carcinoma. So you can think it's a PDAC liver metastasis. We all wanted to emphasize that this is a multidisciplinary teamwork. Sometimes even there's a biopsy, it might be checked. You all, as a clinician, we have to check the imagings if there is something wrong, because only reading the reports, don't forget in this many hospitals, the radiology imagings are being reported by someone who doesn't have anything to do with the patient, sitting at home from the computer, fastly recording the report, sending to the center, nothing to do with the patient. So we need to work in close cooperation with radiology, pathology, endoscopic ultrasonography, and MDT boards to decide best for the patient. That was the reason why we wanted to. This was a duodenal neuroendocrine tumor with liver metastasis, now 3 years of follow-up and alive without any recurrence. I just wanted to share this. For all the cases we have chosen, we just wanted to discuss. There is no perfect story in this area. We are trying to get as close as we can to the perfect site. I'm really feeling myself blessed regarding all the disciplines that I'm lucky to have the chance to work with: pathology, radiology, gastroenterology, our surgical team. Yes, I feel blessed, and I would like to thank all of them for giving us the chance to build up all these successful programs as much as we can. We want to go further. I would like to thank the director of the Turkish HBB Association, Mustafa Kerem, for convincing us to take more part in HBB surgery in the nationwide. Thank all of the disciplines, especially Volkan, Adsay and his team, Emre, our mentors, Aydın, Alper, Orhan, Bilge, and I'm so happy to have Koc here today as well. I would like to thank all of you to help us to discuss all these things, and I would like to thank everyone who followed us from Zoom and YouTube. While we are finalizing these discussions with the case, any questions, any final comments about today's meeting or for further future discussions, I would like to give chance to finalize our meeting. For the last patient? Yeah, re-evaluation of the primary biopsy and check for the Volkan, Adsay, I just want you to, you have lots of efforts, today's meeting and our practice. I just want you, finalize today's, evaluation because it's pathology courses for HPB surgeons. I would love to have you finalize the meeting.
Perfect. Thank you very much for the great opportunity. Always great to see pathology to be appreciated, and if you can really contribute to what you do as surgeons, gastroenterologists, to your daily life, to your practice, if you can have more, of course, it's more the better. I thought this was a great conference. Like I said, we tried to select cases, not always perfect. Life is not always perfect. There are things we can really do successfully, and there are things we don't. We just look back and say, oh my God. So I'm hoping we illustrated the spectrum of things. I hate to say this, but I really feel so blessed that I'm working with a fantastic team. I can tell you, I think it's important perhaps to mention, I really think the medicine in Turkey and HPB teams in Turkey are really outstanding. I don't think we announce ourselves and present ourselves as strongly as we could because of the politics. I've worked in multiple institutions in the US. I know their results. I know their skills. I think as HPB, we really stand as good as any HPB in the US. And I'm beginning to appreciate the European groups, so I work with them. So I think we stand as HPB community in Turkey, stand in a great ground, outstanding surgeons, outstanding teams. At Koc, we are really blessed with having really every angle from gastroenterology to cytology to be all experts. It was put together that way. So for me, that's an extra blessing. HPB organization is doing great meetings every 2 weeks. I love joining them as much as I can. I learn so much from those meetings. I hope it continues, the school, etc. And anyone on the Zoom, if they're from other countries, I hope they enjoyed this meeting. Again, we try to present as possible complicated and problematic cases so that it will be educational to everyone. I don't know what else to say, and I guess we're closing then. All right. Thank you very much. All right.
Thank you very much. Yes. Thank you very much. I also really thank to the organizers and all HPB team. Well, we dealt with the difficult cases, but I have a suggestion. I had clear-cut cases, which we can present another meeting if you like, and we can even increase the number of those cases. So if you agree, society, you can make a slide seminar or something, starting with the really cases which really helped, cytology helped, radiology helped, just clear-cut, and we managed it. I mean, we did it, not always the problems. So let's do my cases in another meeting of that
We
kind.
can share it.
No,
We can share it in the national meeting every 2 weeks. We can make a short.
Perfect.
If Professor Kerem says okay, because there we discuss our cases.
Perfect.
We consult our cases.
Okay.
We can announce there for a short presentation of typical cases. That will be lovely, but we will decide and let you know.
I mean, that's not a caprice thing. It's not a caprice. Just I want to give a message that it is possible. We don't talk about always the most difficult cases. I mean, most are solved and most are clear-cut. So we can show those pitfalls, how to make it better. Thank you very much. It's a great society. Thank you for this meeting.
Peki, bana diyecek bir şey kalmadı. Herkes kapanışı yaptı. Çok güzel bir toplantıydı Emre hocam. Başta Mustafa Kerem hocam, Gürkan hocam. Emeklerinize sağlık Volkan hocam. Eğer müsaade ederseniz 2 haftalık toplantıları, video toplantısı hep aynı kapatıyorum. Eğer müsaade ederseniz oturma son vermek istiyorum. Herkese iyi akşamlar.